Usually, when we talk about severe physical trauma, right, the kind that results in some sort of tissue degeneration or like a loss of physical function, there's usually a visible cast.
Right, exactly. Like you see someone on crutches, you understand they're in pain, and you hold the door for them.
Yeah, exactly. But when you step into the world of postmenopausal women's health, the most profound structural failures are, well, they're entirely invisible to the outside
Oh,
world.
completely. It's this biological reality happening entirely behind closed doors.
Right, affecting millions of people who are pretty much just expected to, grit their teeth and live with it.
Yeah, and I mean, we culturally accept that aging brings changes, sure, but we rarely discuss the sheer physical agony that can actually accompany the loss of estrogen.
It's just swept under the rug.
It really is, because the tissues we are talking about here are highly specialized. And when they are starved of the hormones that keep them, elastic and hydrated, the resulting friction and fragility can completely alter a person's life.
So today, we are focusing on that exact physiological reality for this deep dive. We are looking at genitourinary syndrome of menopause, which is widely known as GSM.
Right.
And we're zooming in specifically on vulvovaginal atrophy, or VVA. But we aren't just here to identify the problem.
No, we have a very specific focus today.
Exactly. Our mission for you listening today is to answer a central question. How do you treat severe, life-altering tissue degeneration when the standard hormonal treatments are, like, completely forbidden?
Which is a huge issue for so many.
It is. So to get to the bottom of this, we are pulling from a really fascinating stack of recent medical resources. We've got real-world case series, clinical pilot studies on tissue biorevitalization, and some comprehensive gynecological guidelines.
And, to really grasp the gravity of the medical interventions we're going to explore, we first have to understand the baseline severity of VVA.
Right, just how bad does it get?
Well, more than half of all women will experience these symptoms within just like 4 to 5 years of entering menopause.
Wow, half. That's a massive demographic.
It is. And for up to two-thirds of that group, the symptoms are classified as moderate to severe.
So not just a mild annoyance.
Oh, not at all. We are talking about chronic vaginal dryness, severe burning, uncontrollable itching, and dyspareunia, which is the clinical term for painful intercourse.
Right.
It isn't just an inconvenience. It disrupts basic daily comfort, making sitting or walking painful, and it takes a massive psychological toll on intimacy and self-image.
And normally, when someone experiences that level of pain and goes to their doctor, the standard of care is usually, well, pretty straightforward, right? The doctor prescribes local estrogen.
Yes, that's the gold standard.
They give you a vaginal cream or maybe a ring, which delivers the estrogen directly to those starved tissues. And the hormone essentially acts like fuel, plumping the cellular structures back up and restoring elasticity.
And to be fair, for a lot of women, that works perfectly.
Yeah, it does. But the massive roadblock we are tackling today is that local estrogen is, well, it's highly problematic and in some cases entirely contraindicated for specific populations.
Absolutely.
We were looking specifically at breast cancer survivors.
Right, because for survivors of estrogen receptor-positive breast cancers, adding any estrogen back into the body is a highly complex medical calculation.
Because the cancer feeds on it, right?
Exactly. Oncologists are fiercely protective of these patients. The treatment protocols, particularly for those on a class of medications called aromatase inhibitors, are designed to do one thing: aggressively hunt down and block all estrogen production in the entire body.
Wow. All of it.
All of it. The life-saving mechanism of the cancer drug relies entirely on starving the body of estrogen. So introducing even a low-dose localized estrogen cream carries theoretical risks of feeding microscopic, dormant cancer cells.
So it's literally a life or death gamble.
Yes. And many doctors and patients simply will not take that gamble.
Okay, let's unpack this a bit. Because if hormones are completely off the table for these survivors, my mind immediately jumps to energy-based devices.
Ah, right. Lasers.
Yeah, exactly. You see these high-tech lasers marketed everywhere in med spas and clinics under the umbrella of, like, vaginal rejuvenation.
If we can't feed the tissue hormones, can't we just use a laser to stimulate it into healing itself?
It is a very logical leap, and it's exactly where thousands of desperate patients have turned.
So how do they work?
Well, the logic behind these devices, usually fractional CO2 or erbium lasers, is based on controlled trauma. The laser essentially vaporizes microscopic columns of vaginal tissue.
Vaporizes. That sounds intense.
It is. This ablative microinjury is supposed to trigger the body's natural wound healing cascade, rushing blood flow to the area to build fresh collagen.
Okay, so it burns it to heal it.
Basically. And over a short window of a few months, studies do show that these lasers can provide temporary relief for dryness and pain.
That sounds promising, honestly. But looking at the medical guidelines in our source stack, there is a massive caveat attached to burning delicate tissue, isn't there? Oh, a huge caveat. It's severe enough that in 2018, the FDA issued a strict safety communication directly cautioning against using these exact laser devices for vaginal rejuvenation.
Wait, a direct FDA warning against them?
Yes, they warned of serious, life-altering potential risks, including severe vaginal scarring, localized burning, and chronic pain.
So it makes it worse.
It can. The underlying issue is that you are taking tissue that is already profoundly compromised, thinned out, and totally lacking the cellular energy to repair itself because of estrogen starvation. And then you are inflicting a burn trauma on it.
Oh, I see.
Yeah, so sometimes instead of regenerating fresh mucosa, the tissue just forms rigid scar tissue.
God, so the treatment meant to cure burning and pain ends up causing permanent scarring and chronic pain.
Precisely. Because of that risk profile, major medical societies, including the North American Menopause Society and the American College of Obstetricians and Gynecologists, classify these laser therapies as investigative.
Meaning they aren't standard care.
Right. They are not recommended as standard first-line care. We simply lack the massive, multi-year safety data required to confidently recommend burning already atrophic tissue.
So for you listening, put yourself in the shoes of a breast cancer survivor for a moment. You have endured grueling treatments to beat the cancer, but those same treatments have thrown you into sudden, aggressive menopause.
And you're dealing with all of the fallout from that.
Exactly. You're experiencing agonizing tissue degradation. You go looking for relief, and you are basically trapped. You have potentially cancer-feeding hormones on one side, risky tissue-scarring lasers on the other, and like over-the-counter drugstore moisturizers that might offer you an hour or two of temporary relief before drying out again.
It is an excruciating medical dilemma. Millions of women are essentially left in the therapeutic void, basically told by the medical establishment to just manage the pain as best they can.
Which means we desperately need a biological workaround. I mean, if we can't use hormones and we can't use lasers, we need something that speaks the body's language to trigger healing without systemic risks.
Exactly. We need a new approach entirely.
Which brings us to the core of our deep dive today. Polynucleotides, or PNs. And I have to be honest here, reading the origin of this treatment felt like reading science fiction.
It really does sound crazy at first.
It's wild. These are highly purified DNA fragments extracted from the gonads of male salmon trout. We are talking about fish DNA being used to cure human vaginal atrophy.
I know, it sounds completely bizarre on the surface, but it is deeply grounded in evolutionary biology.
How so?
Well, the DNA of salmonid fish is remarkably biocompatible with human DNA in terms of its fundamental building blocks. Furthermore, pharmaceutical companies have basically perfected the extraction and ultra-purification process.
Meaning they clean it up.
Yes, ensuring that all the proteins that might trigger an immune or allergic response are completely stripped away, so you are just left with pure structural nucleic acids.
Okay, let's visualize how this actually works compared to a standard treatment.
Sure, I love a good analogy.
Okay, so if an over-the-counter lubricant is like spraying a mist of water onto a dried-out, brittle kitchen sponge-like, it feels wet for a minute, but the water evaporates and the sponge is still brittle.
Right. It doesn't change the structure of the sponge at all.
Exactly. So polynucleotides are more like sending a microscopic architectural blueprint into the sponge factory, ordering the machinery to turn back on and manufacture brand new, springy sponge material from scratch.
That is exactly it. The mechanism of action is what makes this so revolutionary.
Okay, walk us through the science of that.
So when these highly purified polynucleotides are introduced into the thinned, atrophic vulvovaginal tissues, they don't just sit on the surface acting as a slick barrier.
Right.
They undergo a physiological process known as enzymatic cleavage.
Enzymatic cleavage, what's that actually doing?
Well, the human body naturally contains enzymes that recognize these long chains of fish DNA and begin chopping them up into smaller nitrogen precursors. We are talking about releasing nucleosides, nucleotides, and free nitrogen bases directly into the tissue bed.
And those are the literal building blocks of every cell in the human body, right?
Exactly. And as those building blocks are progressively released, they bind to specific cellular receptors. This effectively wakes up the local fibroblasts.
Fibroblasts, so those are the cells that build things.
Yes, fibroblasts are the cellular workhorses of our structural anatomy. Their entire job is to secrete collagen proteins and build the extracellular matrix, which is the scaffolding that gives skin and mucosa its elasticity and strength.
Okay, so during menopause, what happens to them?
During menopause, the lack of estrogen puts these fibroblasts to sleep. They just stop working.
Ah, I see.
And what's fascinating here is that the polynucleotides bypass the need for estrogen entirely. They use nucleic acids to chemically signal the dormant fibroblasts to reactivate, forcing them to start depositing brand new collagen and elastin fibers.
Wow. So it is chemically signaling the tissue to rebuild itself from the inside out rather than just masking the dryness on the surface.
Yes, it creates a true biological revitalization. And by breaking down those DNA chains, it also draws in and holds hydration, which is absolutely crucial for what we call fibroblast trophism, meaning the active nourishment, metabolism, and growth of these cells.
It's utilizing the fundamental language our cells already speak.
Precisely. To rebuild the structural integrity of the mucosa.
Look, the theory is incredibly elegant, but if you are dealing with the agonizing symptoms of VVA every single day, you don't just want elegant biology, you want proof that this actually works in a human body.
Of course, the data is what matters.
So let's look at it. Our source stack breaks down the clinical data across 3 entirely different delivery methods for polynucleotides: creams, injectables, and ovules. Let's start with the topical approach.
The cream study is a great place to start.
Yeah, so the cream data comes from a real-world case series involving 61 women. And this is important because it wasn't a highly controlled, artificial clinical trial with hand-picked ideal patients, right? This was everyday medical practice.
Exactly. These women were instructed to use a specific polynucleotide-based cream, applying it intravaginally and to the external vulva daily.
In the cream itself, it's not just a standard lotion.
No. To clarify a term you might see in the literature, the cream is CE marked, which simply means it has passed rigorous European safety, health, and environmental protection standards for a medical device. It's not an unregulated cosmetic.
Good to know. And what else is in it?
The formulation pairs the polynucleotides with glycerin, which actively draws moisture into the tissue, and isosterolactate, which helps to immediately soften the rigid mucosa.
And the results they recorded were just massive. I mean, more than 6 out of every 10 women reported significant life-altering symptom relief within just 14 days of starting the cream.
14 days is incredibly fast for tissue repair.
Seriously, and if you've been suffering from severe burning for years, 14 days is the blink of an eye. Translating the specific data points, vaginal burning dropped by nearly 3/4, vaginal dryness decreased by roughly the same amount, and the incidence of painful sex plummeted.
And this is where we loop back to our high-risk oncology patients.
Right, the breast cancer survivors.
The medical literature details a specific observational study focusing on 60 breast cancer survivors. These women were actively on adjuvant therapy, taking those estrogen-starving drugs to keep their cancer in remission, and they were suffering terribly from genitourinary syndrome of menopause.
And they gave them this exact cream.
Yes, they were given this exact polynucleotide cream protocol.
So how did they measure if it worked?
The metric the researchers used to track their progress is called the Vaginal Health Index, or VHI. It's a clinical scoring system that measures tissue elasticity, fluid volume, vaginal pH, and the overall integrity of the epithelial lining.
Kind of a report card for vaginal health.
Exactly. At the start of the study, their average VHI score was a dismal 11.9, indicating severe, highly fragile atrophy.
And after?
After 6 months of using the non-hormonal cream, that average score jumped to 17.6.
Wow, that's a huge leap.
It is. That leap represents the difference between tissue that tears and bleeds during normal daily movement and tissue that functions comfortably. The researchers also noted improvements in urinary symptoms, which frequently accompany vaginal atrophy, as well as a return to sexual function.
And all of this was achieved without introducing a single drop of systemic or local estrogen into these high-risk cancer survivors.
Completely non-hormonal.
So the daily cream clearly works as a powerful topical intervention. But the sources also detail an injectable protocol, which, I'm going to be honest, injecting anything into the vaginal wall sounds incredibly intense.
It sounds daunting, yes.
But the clinical data is hard to ignore. This was the pilot study of 19 postmenopausal women who underwent a sequential injectable treatment. They received 3 priming sessions where polynucleotides were injected directly into the tissue, followed by 2 consolidation sessions using injections of hyaluronic acid.
The specific sequence of this protocol is what makes it so effective. It leans heavily on the cellular mechanisms we discussed earlier.
Because the PNs have to go first, right?
Right. Yes. The polynucleotides act as the biological primer. They are injected deep into the mucosa to wake up those fibroblasts and force them to build a fresh scaffolding of collagen and elastin. Yeah. You have to build the structural matrix first.
Right. You need the scaffolding before you add the drywall.
Exactly. Once that new biological architecture is under construction, you bring in the hyaluronic acid.
Now, hyaluronic acid is famous in the skincare world because a single molecule can hold up to 1,000 times its weight in water.
Precisely. So by injecting the HA after the polynucleotides, you are taking a massive payload of deep, profound hydration and delivering it directly into that newly built tissue scaffolding.
So going back to our analogy, the polynucleotides build the sponge and the HA floods it with water.
That's a perfect way to picture it.
And the results back that up. By day 90 of the sequential protocol, the symptom scores had absolutely plummeted. More than 3/4 of the women saw their chronic itching vanish almost entirely. Soreness and tingling dropped by 70%. Even objective vaginal dryness fell by nearly 60%.
And there's a really important detail in that study cohort.
Oh, right. The Sjogren's patient.
Yes. What makes this study particularly compelling is that it wasn't just standard postmenopausal women. The cohort included a patient suffering from Sjogren's syndrome.
Which is a brutal autoimmune disease, right?
It is. It's a condition where the body essentially attacks its own moisture-producing glands, causing catastrophic dryness across the whole body.
And it still worked for her.
It did. Even in a patient with a systemic autoimmune barrier, the injectable protocol successfully rebuilt the tissue.
That is incredible. Okay, so we've covered creams and injections. The third delivery method, our sources cover, offers a sort of middle ground between a daily cream and a clinical injection. Vaginal ovules.
Right, the ovules.
These are solid, bullet-shaped suppositories designed to be inserted high into the vaginal canal where they slowly melt at body temperature.
Exactly.
But how does an ovule physically differ from just, rubbing a cream inside?
Well, it comes down to sustained contact time and coverage. When an ovule melts, it creates this bioadhesive film that coats the entire upper vaginal tract and the cervix.
Oh, so it sticks around longer.
Yes, it creates a prolonged, slow-release environment, bathing the mucosa in polynucleotides and hyaluronic acid over many hours, whereas a cream might be absorbed too quickly or just physically wiped away.
Got it. And the survey on these ovules was really interesting.
The data on that one is phenomenal.
Yeah, in a survey of 45 women using these specific ovules, the investigators noted a dramatic, visible improvement in mucosal thickness and integrity. At baseline, the vast majority of these women presented with severe atrophy.
Right.
But by the end of the observation period, 91% had improved so much they were classified as having only mild atrophy or no atrophy at all.
And the terminology they used in that study is really important.
Yes. There was a specific Latin phrase the researchers used in the ovule study that really captures the magnitude of this. Restitutio ad integrum.
That translates directly to a complete restoration to the original undamaged condition.
A complete restoration. Over a third of the women in that 45-person survey experienced restitutio ad integrum. Their tissue reverted entirely to a healthy, thick, premenopausal state. They were effectively cured of the physical tissue degradation.
Finding that over 35% of patients achieved total restoration is a remarkable clinical milestone.
It's unheard of with standard moisturizers.
Totally. It proves that if you supply the raw biological materials for DNA repair and cellular hydration, the human body is entirely capable of reversing the atrophic process, even in delicate mucosal tissues.
Okay, but I have to play devil's advocate here for a second. Wait, salmon DNA, hyaluronic acid, fibroblast activation. This cocktail is exactly what dermatologists and plastic surgeons inject into people's faces to fix wrinkles and hollow cheeks.
It is the exact same underlying technology, yes.
Right. It sounds identical to modern aesthetic biorevitalization. So are we just taking a trendy cosmetic procedure and applying it to the pelvis? I mean, is this actual functional medicine or is it an intimate cosmetic trend?
That is a very fair question.
And furthermore, just because it's non-hormonal doesn't mean it has zero side effects, right? We need to look critically at the caveats.
It is a vital distinction to make, and you are entirely correct about the origins. This technology absolutely was born in the realm of aesthetic medicine and dermatology.
So it is cosmetic.
Well, doctors have used polynucleotides for years to repair severe UVB-damaged skin on the face and to heal chronic, stubborn diabetic skin ulcers. The biological mechanism of healing tissue is identical. However, when we apply this to the vaginal mucosa, we cross a massive line from aesthetic medicine into deeply functional medicine.
Because fixing a wrinkle changes how you look, but fixing vaginal atrophy changes how you live.
Exactly. When you restore the thickness and compliance of the vaginal wall, you aren't doing it for aesthetic reasons. You're restoring a woman's fundamental ability to walk without friction burns, to sit in a chair comfortably, to maintain the structural support needed for urinary tract health, and to engage in a pain-free sexual life.
So the mechanism might have roots in aesthetics, but the application here is purely restorative functional medicine.
Yes. The goal isn't cosmetic, it's basic human function.
But it's not a magic, flawless cure-all. The studies do note side effects.
They do, and transparency is critical here. In the clinical observations for the creams and the ovules, a small percentage of women reported experiencing transitory mild burning, itching, or local discomfort immediately following the application.
Right. But the clinical literature specifies that these reactions were localized, generally only lasted for a few hours, and resolved entirely on their own without needing any secondary medical intervention.
Yes, the adverse events were minimal and fleeting. And, when you weigh a few hours of mild, temporary itching against the severe risks we discussed earlier.
Like the permanent chronic pain and scarring associated with laser therapy?
Exactly. Or the life-threatening systemic risks of introducing hormones to a breast cancer patient. The safety profile of polynucleotides is incredibly favorable.
But we still have to be careful.
Oh, absolutely. As with any emerging medical application, we have to aggressively manage expectations and acknowledge the limitations of the data we currently possess.
Right, the major limitation being the scale of the evidence. I mean, we are looking at pilot studies of 19 women or observational cohorts of 60 women.
The sample sizes are undeniably small.
Very small.
While the results are overwhelmingly positive and the underlying biological mechanism is scientifically sound and proven in other tissues, the global medical community operates on a strict hierarchy of evidence.
They want the big trials.
Yes. To shift polynucleotide therapy from an innovative alternative to a globally recognized standard first-line care protocol, we need large-scale, long-term, randomized controlled trials. We need studies involving thousands of women, tracked over multiple years, comparing the polynucleotides directly against placebos.
And another crucial reality check for anyone listening, this is not a one-and-done permanent cure, right? The results require strict maintenance.
That is a critical point.
Because menopause is not a temporary sickness you recover from, it is an ongoing, continuous physiological state. You might undergo an initial intensive protocol of injections or daily cream application, but aging doesn't stop.
It never does.
Eventually, those fibroblasts will go back to sleep. You will likely need maintenance injections every few months or continuous habitual use of the topical cream to keep the cellular machinery turned on.
And that is simply the nature of managing any chronic degenerative condition. You are continually pushing back against the body's natural, irreversible estrogen depletion.
It's an ongoing battle.
It is. But consider the perspective of a breast cancer survivor who was previously looked in the eye by her doctor and told she had absolutely zero safe options to treat her pain.
Yeah, that's a hopeless place to be.
Totally. So having a maintenance protocol that requires applying a cream or getting a periodic injection to actually rebuild her tissue isn't a burden. It is a monumental, life-altering medical breakthrough.
It really represents a total paradigm shift in postmenopausal care. So let's wrap this up and summarize the journey we've taken through these sources.
Let's do it.
The central question we started with was whether polynucleotide therapy can genuinely improve tissue compliance and comfort for women who cannot rely on traditional estrogen. And the clinical evidence, from the cellular theory to the real-world trials, strongly points to yes.
Very strongly.
Polynucleotides offer a highly promising, scientifically backed, non-hormonal avenue to physically rebuild the compromised structures of the vaginal and vulvar tissues.
Whether that's delivered through daily creams, slow-release ovules, or sequential injections paired with hyaluronic acid.
Right. The treatment utilizes the very building blocks of DNA to wake up dormant cells, basically demanding they build new collagen and lock in vital moisture.
It addresses the root structural cause of the tissue frailty, rather than just temporarily lubricating the surface. And it does so without introducing the systemic hormonal risks that make traditional therapy an impossibility for so many vulnerable women.
So, think back to that invisible cast we discussed at the very beginning of this deep dive. For decades, the profound physical degeneration of vulvovaginal atrophy has been treated as a silent, inevitable burden that women simply had to carry, especially those who had already survived the trauma of cancer.
A burden they shouldn't have to carry alone.
Exactly. But by harnessing the fundamental language of biology, it seems we might finally have a way to heal what is broken in the dark.
And, if we connect this to the bigger picture, the implications are just staggering.
Oh, how so?
Well, we are now taking the fundamental building blocks of DNA, extracted from nature, and using them to essentially trick our bodies into repairing their most delicate, rapidly aging tissues entirely without the use of systemic hormones.
Wow. Yeah, that is wild to think about.
It makes you wonder what other age-related or degenerative conditions in the human body could we reverse, simply by learning to speak the biological language our cells already understand?